Hi, welcome to this Critical Care Now presentation on mechanical ventilation. Today we'll be talking about perks and pitfalls of PRVC. My name is Matt Siuba. Here we go. We'll start with a case. We have a 72-year-old patient who is admitted to the ICU with pneumonia and acute kidney injury, and the following ABG results: pH 723, PCO2 28, PaO2 75 with a serum bicarb of 8. This person is already on high flow nasal cannula at 60 liters a minute and 80% oxygen. Despite that, the respiratory rate is rising, the tidal volume is falling. This person has impending respiratory failure and the decision is made to intubate. After an uneventful intubation, the therapist asks you for ventilator settings. You choose PRVC with a tidal volume of 8 per kilo, a rate of 20, PEEP of 10, and an I time of 0.8. You look over everything and think it's probably good enough, so now you walk away. Pressure-regulated volume control has many names and it depends on the type of ventilator you're using. This is called VC Plus on a Puritan-Bennett ventilator. On a Draeger ventilator, it's called autoflow. Finally, on a Hamilton ventilator, this is called adaptive pressure ventilation. Unfortunately, none of these names tell you what this mode actually does. Is this volume control? Is it pressure control? Is it some sort of hybrid? What exactly is going on here? This is actually a pressure control mode of continuous mandatory ventilation, which many people know as assist control. Most importantly, though, is the targeting scheme. This is an adaptive targeting scheme, which is different than most of the modes that you're used to using. There's a lot of value in defining modes this way, so I recommend you read more about it at this PubMed link.
I promise you what Matt just said is not contradictory. Yes, the mode is called pressure-regulated volume control ventilation, and yet each breath is still a pressure-controlled breath. How is this? And the answer is we set a tidal volume. We know we set a tidal volume. The ventilator, based on the mechanics that is measuring, sets a pressure for each breath and gives a pressure-controlled breath for each inspiration. If the volume's not met with that breath, the next breath is going to have an even higher pressure. So yes, we set a tidal volume, and in our traditional thinking of things, this is kind of a volume controlled ventilator, but each breath that the ventilator gives, it gives in a pressure controlled manner. And it does this by calculating the equation of motion. And I'll throw back to Matt and he'll talk about that.
So what we're saying here is I'm using a pressure control mode to achieve a target tidal volume. So how might I achieve that? To understand it, we're going to have to learn about the equation of motion. The equation of motion states that the pressure given by the ventilator plus the pressure from the patient's muscles is equal to the volume times the elastance plus flow times resistance. Practically what this means for a given target tidal volume and a given elastance, flow, and resistance, the vent pressure will depend largely on the effort from the patient. Let's look at that graphically now. What this really means is, as the effort from the patient is increased, the support from the ventilator will be decreasing. To illustrate this further, let's look at a passive versus an active ventilator waveform. You can see here on the flow diagram, as patient effort is increased or there is active breathing, the pressure waveform will get deflected downwards. To say this another way, increased muscular pressure for the patient will cause decreased pressure delivered by the... So now you're probably asking yourself, how should I actually use this mode? To understand that, we need to review the goals of invasive mechanical ventilation. Here's a good PubMed link for you to read more about this. Our three main goals are safety, comfort, and liberation. When we think about safety, we're mainly talking about ensuring a safe minute ventilation and decreasing the risk of ventilator-induced lung injury. In terms of comfort, we think about a balanced work of breathing and increasing synchrony. When we think about liberation, we're really talking about identifying extubation readiness, otherwise known as #alwaysbeextubating. So where does PRVC fit into this paradigm? From a safety standpoint, ensuring minute ventilation is there. Villi prevention is a little bit unclear, it depends on how consistent the tidal volumes are. From a comfort standpoint, flow synchrony here is excellent and one of the major benefits of PRVC. When we think about balanced work of breathing, this is one of the potential pitfall areas of PRVC, which we'll discuss in more detail. From a liberation standpoint, one could think about PRVC as having an auto-wean potential. Let's dive into this balanced work of breathing issue in a couple different scenarios now. Consider a post-op patient who is a, quote, wean to extubate, who is just waking up from general anesthesia, Or, similarly, a polysubstance overdose patient. You are simply waiting for these patients to develop enough PMUSC to be weaned from the ventilator, so auto-weaning in PRVC would be helpful. Scenario 2 is very different, on the other hand. This is a patient with severe lactobacillosis and who is very acidemic with a pH of 7.12. Their work of breathing is going to be sky high. Therefore, their PMUSC is sky high. Therefore, the support they're going to get from the ventilator is going to be minimal and in some cases will be zero. Consider our diagram from earlier. This is an extremely unhappy scenario that results in respiratory muscle fatigue. So with this information, let's return to the case from the beginning of our talk. We have a patient with severe metabolic acidemia with a high respiratory drive. This is an extremely poor PRVC candidate. Now this may seem obvious to you, but unfortunately this happens on a daily basis in ICUs over and over. So let's wrap up on all these concepts we talked about today. When we think about PRVC or similarly named modes, this is a pressure control mode of continuous mandatory ventilation that is adaptive in order to provide a target tidal volume. There are definite advantages to using this mode, like increased flow synchrony and ensuring a minimum minute ventilation. Additionally, there is the possibility of providing auto-weaning benefits. There are obviously clear negatives to using this mode, and the most important one is the decreased amount of support that a patient will receive when their work of breathing is high. They may be getting zero support, and this patient's going to be tired out and undersupported. The major lesson of using PRVC and other modes is tailor your treatment to the patient, not the other way around. Thanks so much for tuning in for this session on mechanical ventilation. We'll see you next time for some more.